Okay. Bismillah ar-Rahman ar-Rahim. Okay, can we start? Okay. So, our course is related to the study design, okay, of epidemiological research or studies. What kind of study designs did we cover last time? Cohort, but before cohort, the first one. Before. Case series. Case series and population-based case series, which leads or end up with registers of disease. And then cross-sectional study. What's the main objective of cross-sectional study? To measure the prevalence of a disease. Excellent. Okay, what's the inconvenience of cross-sectional study? No temporality, because you measure at the same time exposure and disease, or causes and disease. Okay, what next after cross-sectional? Cohort study. What's cohort study? To know the incidence. Very good. Because we start with groups free of disease, exposed to factors, to causes of disease, and non-exposed. And we follow them over time to measure the number of cases that will emerge in the exposed, which is the incidence among exposed, and to measure the cases that will emerge from non-exposed, which is the incidence among, very good, the ratio of incidence of exposed divided by the incidence of non-exposed. What is it? What is it? Okay. It is the risk ratio and relative risk. And I prefer risk ratio. You know why? Because incidence is a risk. So incidence among exposed divided by incidence among non-exposed is a risk ratio. It's a ratio of two risks. It's a relative risk. That's true. Okay. What else can we calculate from these incidences? The risk difference, which is incidence among exposed minus incidence among non-exposed. What is the meaning of this difference? What does it measure exactly? No, before. I said the risk difference. The risk difference, the incidence among exposed minus the incidence among non-exposed. What does it measure? The number of cases that are caused by other factors. تذكروها هذه? Remember this. We'll see this in the causation later on. And then we measure the attributable risk, which is the risk proportion, the proportion of cases that are attributed to this risk factor. Okay? What's this? The formula of this attributable risk? Risk difference divided by incidence among exposed. هذه ضايعين فيها شوية. We're a bit lost. We'll see it later on. I know that it is a bit difficult concept, but it is the proportion of cases that we can prevent if we remove this cause or this risk factor. Because the disease is the result of many risks. And you cannot control all the risks. You will focus on the most important ones. أعطيكم مثال. لما تحبوا تنزلوا عدد الحالات متاع سرطان pulmonary يعني شو اسمه هذا cancer of the lungs. You have several risks. What is the first risk and main important? Smoking. What is the second one that might be important? Pollution, air pollution, مثلا. Maybe genetic factors, etc. You will focus on smoking because it is the most important. Your question is, if I reduce the exposure to smoking, how many cases or which proportion of cases will I be able to reduce. So the attributable risk to smoking will give you exactly this proportion. احنا we measured it. We'll measure it. We'll see it. كم proportion اللي تجي تنزلها. Because you cannot control all the risks. Some of the risks are not compressible at all. The genetic risks. مش تعمل تبدل الجينوم بتاع البوبيليشن. You cannot. فهمتوا علي ليش it's important the attributable risk. Anyway, now what is the inconvenience of a cohort study? What is the main inconvenience? Time consuming, expensive. You risk to lose cases and controls because the duration of follow-up is sometimes very long, years. And the numbers of cases to start with at the start might be thousands of cases. This is really not easy to do. What is the alternative to have an idea about risk factors? What's the alternative? ايش هو البديل على الكوهورت ستدي؟ يعطيك العافية. Case control study. We started. So how do we compose a case control study? كيف المونتاج بتاع case control study? How do we conceive it? How do we build a case control study? What's the first step? Yes?
We start with the disease affected and the normal people.
We start by finding patients. Who are the cases? And then we choose for them patients, non-patients, normal persons without the disease. What's the main characteristic between cases and non-cases? Of course, cases have to be with disease and non-cases have to be free of disease. هذا أول شرط. في شرط ثاني. What is it? نعم؟ لا. الاكسبوجر تاعو نجيو هذيك في الكوهورت ستدي. The first group is exposed. We start by exposure to risks. Now we start by disease and controls without disease. They must be completely yes. يعطيك الصحة. Comparable. They have to be comparable. ليش؟ لأنه احنا we want to filter the effect of exposure to risk factors من بعد. So we must any kind of nuisance or noise that might make this comparison difficult regarding exposure, we have to so we need to have two comparable groups. الفارق الوحيد ما بيناتهم هو the presence of disease. Okay, this is the design. Cases with disease, non-cases without disease, and then what's the next step? عندنا 100 حالة عندها مثلا سرطان ثدي و100 حالة free of سرطان الثدي. ايش هو المرحلة next step? Yes. يعطيك العافية. We measure the exposure to a risk مثلا a genetic factor. نفرض احنا our hypothesis is the presence of case in the family might be a risk factor, which is true. يعني family يعني هو it occurs there is genetic يعني component in this cancer, so genetic family cases are more frequent among cases than control. So we ask about exposure among those who have the disease as well as those who do not have the disease. And you have this, you remember this 2x2 table, A, B, C, D, exposed, non-exposed cases, non-cases. And you will end up with counting A, C, B, and D. A plus C is the number of cases. B plus D is the number of controls. لكن القيمة متاع ال E وال C وال B وال D ما نعرفهاش. We have to ask. We have to ask, inquire about how many are exposed to the risk that we are measuring among cases and how many are not exposed, and likewise among controls. ايش هي المعلومة اللي مش تعطيها لنا المسألة هذه؟ حسب رأيكم is this right to do it like that? It's right. لكن ليش this is right? What do you expect? هل values متاع ال A وال C وال B وال D if the risk factor is effective عنده قيمة معناتها is really influencing the disease, what do we expect A و B و C و D كيف يكونوا يعني؟ Can you compare them? Can you compare A and C for instance? Exactly, will be significantly higher than C. Will be with D among controls. Exactly, D will be significantly higher than B. صح ولا هذه القصة الكل. This is the whole story. It's an idea يعني. This is the idea. We'll see how we can implement this. So you know this table, this classic table. يعني شفناها حتى في الcohort study. But what's the difference? The difference in the cohort study, we start by exposure and we have big numbers. Now we start by disease or no disease. We have smaller numbers and the two groups are comparable. So now I have to define something. حابكم تنتبهوا لي because it's a bit difficult. The concept of odds. Odds اللي يمشي يعرفوا الخيل والمراهنة على الخيل يفهموها القضية هذه. The odds. The odds of occurrence of an event, the odds is the chances of an occurrence of an event divided by the chance of non-occurrence. يعني هو هذا الريشيو الodds. مثلا الodds of exposure among those who have the disease, what is it? ترى قولوا لي. What's the odds of exposure among the disease group? نعم؟ No, what the odds is a fraction. ها؟ صحيت. It's A over C. يعني chances of occurrence which is the exposure اللي هي A divided by chance of non-occurrence اللي هي C. It's A over C. وبالنسبة للodds of exposure among no disease, what is it? B over D. فهمتوها هذه بربي الكل ولا لا؟ فهمتوها؟ هذه يستعملوها هذه في المراهنة على الخيل. They measure over time كم مرة الفرس هذا ربح وكم مرة خسر. And they measure the odds. اللي يلقوا عنده odds عالي هذاك يراهنوا عليه. Now we'll see the implication of this concept. Odds of exposure in diseases to the risk is A over C. Odds of exposure in non-disease is B over D. باهي. We are interested to know a quantity called the odds ratio. The odds ratio is the ratio of the two odds, A over C divided B over D. في الآخر هذه, if you do it mathematically, it becomes AD divided by BC. صح ولا لا؟ موافقين على الكوانتيتي هذه ولا لا؟ AD over BC. This is what we call the odds ratio. سمعتوا به odds ratio? The odds ratio. So in case control studies or in cross-sectional studies with the control group where there are exposed, non-exposed disease and non-disease, we can calculate what we call the odds ratio. This odds ratio will give us an idea about how important is this risk factor. So if the risk factor is important, how do we expect this odds ratio to be? Big, greater than 1. Big. خلينا نشوف مثال. أول حاجة خليني نرجع لكم للتيبل باش نفسر لكم. الodds ratio very simple. هذم اللاترال cells هذوما هذه وهذه multiply them. You divide them by these two cells, BC. A multiply D divided by B multiply C. This is the odds ratio. So it's very easy, really. واضح؟ بقى let's calculate an example. We have this example. We have 260 cases of coronary heart disease. We chose for them 340 cases as controls, free of coronary heart disease. And we are asking about smoking exposure. In the 260, 120 are smokers, 140 are non-smokers. However, in the controls, free of disease, 80 out of 340 are smokers and 260 are non-smokers. You see this? This distribution inside the 4 red cells is extremely important. Now, tell me, what's the odds ratio?
120 multiplied 260 over 140 multiplied by 80.
Yes, it is 120 over 140 divided by 80 over 260. And it becomes 120 times 260 divided by 140 times 80. صح؟ هكا بالضبط. And it is 2.78. What does it mean? How we can read this? How we can read this? ايش هي الكونكلوجن لما توجدوا odds ratio with this value 2.78. Positive association between coronary heart disease and smoking, and smokers are 2.78 exposed. Patient of coronary heart disease are almost 3 times exposed to smoking, or more simply, smoking exposes 2.78 times to coronary heart disease. واضح? It's like the relative risk تقريبا, same interpretation, but the approach of calculation is different. Instead of having a cohort study, 2 groups, and you follow them for 3 years, you have just to choose cases and controls and ask about the risk factor. So it's shortcut. It's easier. But it ends up with similar results. Okay? هذه الكونكلوجن. Interpretation. So if odds ratio is equal 1, ما فيش حتى تأثير. The risk factor doesn't increase the incidence. If odds ratio is greater than 1, there is a positive association, so the exposure is a risk factor. If it is less than 1, it has a protective effect. And this is the case of exposure to what? To vaccine. Okay? فاهمين. Okay, good. Now we have a summary of all what we did. Quizzes. 1 2 3 4 5 20 كويز. باهي في كل كويز مش يجاوبني واحد. تو عندنا the design. This is what we did so far. Case series, cross-sectional, case control, and cohort. صح ولا لا? We covered all this. Now, I want to ask you for every type of study, if it is descriptive or analytic, if it is retrospective or prospective, if it is observational or experimental, if we begin with disease or with the cause of disease, means the risk factor, and if we need a comparative group or no comparative group. سهل؟ واضح السؤال؟ Let's start by case series. Is it descriptive or analytic? Very good. Retrospective or prospective? Very good. Observational or experimental? Very good. Beginning with disease or cause of disease? Excellent. Comparative group, yes or no? No. Very good. You are wonderful, ما شاء الله عليكم. Cross-sectional. أيه في صوت. Yes. Retrospective, prospective. Retrospective. Observational, experimental. Very good. Beginning with disease or cause of disease? ما شاء الله عليكم. I am very impressed. I am very proud of you بالحق. You understood everything. But comparative group, yes or no? Yes. Usually yes. You can do it without, but usually yes. But case control. Descriptive or analytic? يعطيكم العافية. Retrospective or prospective? شكون قال prospective؟ قيم ايده. It is a retrospective. We start disease occurred in the past and we ask about exposure in the past. ردوا بالكم. It's retrospective. Observational or experimental? Beginning with disease or cause of disease? With disease. صحيت. Comparison group, yes or no? Control, it's case control, of course, yes. Cohort, descriptive, analytic. Retrospective, prospective. Very good. Observational, experimental. beginning with disease or cause of disease? Comparison group, yes. But a trial هذوما experimental studies when you clinical trials. Analytic of course, but prospective ولا retrospective? Observational or experimental? يعطيكم الصحة. Beginning with disease or cause of disease? هاي ترى قولوا لي كان تعرفوا. يعطيكم الصحة شكون قال cause of disease؟ Usually clinical trials we have patients, we try new drugs on them. So we try with disease, we start with disease. Usually. But we can start with causes of disease. Comparison group or no comparison group, we need in RCTs, randomized controlled trials, يعطيكم الصحة. I'm happy you understood the study designs. I'm proud of you. ما ينخاف عليكم. There is also another graph that summarize. I took this graph from Lancet. تسمعوا بها Lancet. Lancet هي واحدة من المجلات الطبية الراقية جدا يعني معروفة. So the first question, did the investigator assign exposure? هو اللي يعطي exposure, yes or no? If it is yes, it becomes an experimental study. And if we randomized, تسمى RCT, randomized controlled trial or non-randomized controlled trial. هذا بصفة عامة these experimental studies you will not do in life ولا شوية. Only those who will become specialized in epidemiology will do randomized controlled trials, will try new drugs, etc. This is high level. But if no, we are dealing with what we call observational studies. لأن احنا we observe. We don't assign smoking to people. We observe what happens among smokers. We don't assign obesity among people. We observe the result of obesity. They are observational studies. But we can assign one drug, totally experimental. Now we are dealing with observational, and depending on the presence of control group, we have either, if we have no comparison group, it becomes purely descriptive, اللي هما الكيس series ولا population case series هذا هما without control group. We are dealing only with patients. If we have control group, patients and non-patients, it becomes an analytic study. And you'll find the three designs that we had covered: cross-sectional, case control, and cohort study according to the direction in time. شوفوا. So if the exposure, let's start by the cross-sectional. If we measure at the same time as in a snapshot, exposure and outcome, this is a cross-sectional study. If we measure exposure at the start and we try to measure the outcome through time, it becomes a cohort study. And if we measure the exposure retrospectively, we start by the outcome and we go back to ask about the exposure. This is a case control study. This graph summarizes everything also. واضح? Is this graph clear? Okay. Now, I will pass quickly about another type of studies that doesn't measure the events on the individual level. ركزوا معي شوية. In all the previous studies, our unit of measurement is the patient, is the individual. We have surveys or medical health records or whatever source of lab data that is related to one individual. Now, in some studies, we measure outcomes or we measure diseases in a group of population. And we try to relate it to some factors. We'll see examples. These are ecological studies. So the unit of analysis is rather a group, mostly defined geographically in countries. مثلا ناخذ the rate of cancer in Bahrain, in Kingdom of Saudi Arabia, in Oman, etc. This is, so we measure مجمل هذا الأمر في مجموعة سكانية كاملة. You can imagine that what we are measuring is among the total population. It doesn't mean that everyone in the population has exactly the same risk. and it's a global measurement. And we can measure the incidence, prevalence or mortality. يعني ناخذ المورتاليتي ريت في بلد مثلا، incidence rate of cancer في بلد. واضح؟ We can do يعني curves like this or correlations like this. We try to correlate the colon incidence, colon cancer incidence with the daily meat consumption. And you see there is يعني a kind of trend of increase with the consumption of meat, of red meat. صح؟ يعني وهذه every dot is the incidence in a country. From the countries who consume low quantities to those who consume high quantities like USA and Canada here and New Zealand. They have the highest incidence. So what does this show? What can you tell from this graph? The more you consume, the more your risk increase. Bahi. Can you say that any person who consumes more higher levels will have higher risk of colon cancer? You cannot say. يعني you can in a way deduce some hypothesis, like you cannot really infer or go back to the individual and generalize this result because it was measured at the country level. What's the problem? In a country there is a lot of variation between people. Genetic makeup is not the same. He can consume red meat, but at the same time he has excellent lifestyle. He eats more vegetables and he has more protective factors, less genetic factors. So you cannot generalize to individuals from this. هذا هو So you see the characteristic of ecological research. This is another example. So the per capita supply of calories and incidence rate of breast cancer. And you know that obesity increases the risk of breast cancer, and this is kind of ecological study. When we say ecological study, we measure the incidence or the mortality per geographical unit, not per individual. And we cannot generalize the incidence that we find here for the US to all individuals in the US. This is the main conclusion that you must keep in mind. The unit of measurement is not the individual, it's the country, it's a group of individuals, and we cannot generalize the results to individuals in this country or in other countries. Okay. Well, so the advantages, it can propose or suggest some hypothesis for causal relationships, and the disadvantages is that risk factors are not measured among individuals but among groups of individuals. So these are the take-home messages for study designs. So we discussed 4 main study designs: case series, cross-sectional, case control, and cohort studies. And you know the differences between them now. Okay? And we covered the advantages and disadvantages of every study design. We calculated measures of association for cohort studies, which is relative risk, and for case control, which is odds ratio. It tells us about the strength of the association between risk factors and diseases. And we interpreted the meaning of relative risk and odds ratio according to their value compared to 1. 1 is the absence of relationship, association. Greater than 1 is a positive association, and lower than 1 is a protective effect. Okay? We discussed the design of ecological studies. هذا كله مفهوم? We did that? You agree? Excellent. Okay, now we will have for half an hour another lecture about the causation or causal association. اوكي. في أسئلة على study designs؟ واضح؟ اوكي، good. Now, we calculated the measures of association. Now we are going to move a step forward. When we do epidemiological studies, our aim is to identify the causes of disease. But the causes, we start by measuring the association. How we measure the association? What are the measures of association that we covered so far? And, yes, odds ratio and relative risk. Are they enough to confirm that the association is causal, even if this association is high? Odds ratio is far greater than 1, or odds ratio. Does it mean that this risk caused the disease? Let me tell you an example. Imagine you have a study measuring the association between having هذه يسموها الولاعة lighter, yes, lighter, and risk cancer, شو اسمه هذا pulmonary cancer. Will you find an association? You will find an association because smokers smoke using the lighter. Does it mean that having lighters caused the pulmonary cancer? No, because there is another intermediate factor, which is smoking. You are measuring another factor that is associated but not causing the disease. So the association, the strong association, doesn't mean causal association. There are more conditions that we will cover now. هذا حبيت تذكروا ديما الإكزامبل هذا to remember that the strong association doesn't mean automatically a causal association between a risk and a disease. So our learning objectives today is to recognize the difference between association and causal relationship. And we will discuss the steps that will lead us to a causal relationship. There are steps that we have to go through to demonstrate the causal relationship, to identify the different statistical measures of association that you know, odds ratio and relative risk, and recognize the different causation criteria. I will list them to you, and I will cover 3 of them, the most important, okay? These are your learning objectives today. Okay, so the first step to have a causal relationship is an association, and it has to be significant. Do you know what is a significant, statistically significant association? شفتوها هذه في الير 1 مع دكتور أحمد جرادات. What is statistically significant association? It is an association that is not caused by chance. So you remove the effect of chance. And because what we call, you covered this in year 1, random variation can cause some kind of association, but this is not statistically significant. It is related to this p-value or type 1 error. It has to be less than 0.5. The association has to be not caused by chance. It has to be significant. This is the first condition. So, significant association. Second is to demonstrate that this association is direct and not indirect, not explained by another factor, as I said, between the lighter and lung cancer. It is direct association. Or, of course, you can have no causal association at all. Indirect means the factor exerts its effect through intermediary factors, like poverty and TB. Poverty doesn't cause TB directly. It causes reduction in the immune system because of malnutrition. And malnutrition and reduction of immune system can cause to overt TB, because a lot of people have asymptomatic TB, which is a skin test positive without clinical disease because their immune system is strong. Those who face poverty have a low immune system, So they will have the disease, the full-blown tuberculosis, the disease with all the symptoms, the severe form of the disease. You understand? So the factor can exert its effect through intermediate factors. So there are three main steps that we are going to cover. The first one is the calculation of the association with odds ratio and relative risk. And the second one is to test the temporality. And it's a must. If it is a cause, it has to precede the disease. Otherwise, there can be association, but there is no sequence in time. You have to prove the sequence in time. And then you have to eliminate alternative explanations. Okay. So the statistical association means that the risk factor must be high, significantly high. What does it mean in terms of relative risk and odds ratio? Their value? Significantly greater than 1. هذا ايش معناتها, right? Or, if it is protective, it has to be significantly less than 1. Okay, so basically I go back to this 2x2 table for cohort studies and case control studies. So the association, the strength of the association, usually we do it with cohort studies or case control studies. And we have this classic 2x2 table when we have risk factor positive, negative, and disease present and absent. Yani for the two type of studies, case control or cohort, you end up with a 2x2 table like this. And you know how to calculate the let's start by the relative risk or the risk ratio. What is the relative risk here? What's the formula of the relative risk here?
A over B divided by C over D.
لا توا ما تفهمناش. In which study design we are? قلت لك relative risk. Relative risk, which study design we measure relative risk? Cohort study. How we calculate the relative risk? Incidence among exposed. صحيت. أي mathematically here, what is it? A شوف هنا. No, A over A plus B, this is incidence among exposed, divided by C over C plus D. صح ولا لا? This is the relative risk from a cohort study. And from, what's the odds ratio from case control study here? صحيت. ED divided by BC. هذيك odds ratio for case control study, this is how we calculate it, and the relative risk for case control for cohort study. واضح؟ So for prospective study, we calculate the relative risk, and then we calculate the attributable risk. وشفناها الattributable risk. We'll cover it by an example. Case control study is the odds ratio, and cross-sectional study is also an odds ratio. واضح? Is that clear? The definition of attributable risk. Attributable risk is the risk difference, which is the incidence among exposed divided by the incidence minus the incidence among non-exposed. هذه risk difference, incidence among exposed minus the incidence among non-exposed. What does it tell you? لا بالعكس, هو احنا نحيو number of cases caused by other factors. We have just the number of cases caused by this factor, because we have the incidence among exposed minus the incidence among non-exposed. صح ولا لا? The incidence among non-exposed are the cases that are caused by other risk factors. فاهم علي ولا لا؟ باهي the risk difference هذه when we divide it by the incidence among exposed we have in a way the relative proportion of cases caused by the risk factor ونسميها attributable risk proportion. فهمتوا ولا لا؟ نعودها تفهمها في الاكزامبل ما يسالش. bear with me بعد نرجع لك انت حب. Okay. And this suggests the proportion of cases that can be avoided in a population if the risk factor was removed. هذه قلت لكم عليها من الساعة. I'll go back to it. فسرها لك. Through examples you'll see it. Let's see this example. We have يعني incidence among smokers and incidence among non-smokers. What is the risk difference? الكولون هذه ماينس هذه الصغيرة. الاترibutable risk is really this big risk minus the small risk. الريسك هذايا this risk is caused by the risk factor, let's say smoking, because the risk is smokers, by smoking and non-smokers, they are included here. لكن قداش هما كم هما؟ They are measured here because you have the risk among non-smokers. فالريسك the real risk يعني that is attributed to smokers هو هذا minus this. صح ولا لا؟ فهمت ولا لا؟ Do you understand?
Can we use numbers?
Okay, I'll use numbers. These are numbers. You have in two countries, in USA and in UK. You have the smokers and the smokers, and you are measuring the lung cancer incidence. In the USA, the incidence is 191 per 100,000. And among smokers, and among non-smokers is 8.7 per 100,000. What's the risk difference? صحيت per 100,000. In the UK, what's the risk difference? 159. What's the attributable risk in the US? Divided by 191. لا, the incidence subtracted, سامحني. The incidence subtracted among exposed and non-exposed. بعد تقسم على الانسيدنس among exposed. فهمت علاش؟ مش حفظت بس فورمولا، فهمت هالشيء. Do you understand the rationale behind it? يعني أنت the relative contribution of the risk factor is the difference of the incidence divided by the total incidence. هذه هي الحسبة الأولى. what is the attributable risk؟ احسبوا لي ترى. كيف تحسبوه الاتريبيوتبل ريسك؟ نساوي ال 100,000 مش مشكل. احسبوها هاي. قداش attributable risk in the US؟ 0. كيف عملتها؟ لا الريسك ديفرنس هذه صح؟ 182.3 على شنو تقسمها باش تلقى الاتريبيوتبل ريسك؟ على شنو تقسم؟ الكل هي شنو هي؟ كم عددها؟ اقسمها. Did you do that؟ كم لقيت البروبورشن؟ صحيت 95.1%. يعني ايش معنى الكلام هذا؟ What does it mean؟ Conclusion. Your conclusion. يعني if you remove smoking you can reduce the number of cases by 95%. هذا ايش معناتها؟ Let's see calculation هي نفسها in the UK where you have 166 and 7 among non-smokers, 166 incidents among smokers. احسبوا لي الاتريبيوتبل ريسك proportion. ها؟ نفس الشيء 95%. شفتوا كيفاش؟ These are the values of this attributable risk. يعني proportion. So the first step in causation is to measure the association, the strength of the association. Bye. Now the second condition is the temporality. How can you establish the temporality? What's the study design that you have to use? And the only one. cohort study ما عندكمش اختيار. لازم تشوفوا ناس exposed and you follow them over time for years if needed. So cohort study designs will allow you to prove the temporality. And this graph illustrates the cohort study design. So you have before the exposure, the risk is the same for both, the incidence is the same. When you start exposure, normally the number of cases will increase among the exposed group. Come to this graph. Do you understand this graph? If I ask you, when you see this graph, what does it tell you? Which criteria of causation does it demonstrate? Temporality. Why temporality? Because in the x-axis you have time. واضح? And you have an increase of the incidence following the exposure to the risk factor. You must read carefully the graphs. واضح؟ Bye. This is an example of a cohort study to show temporality between exposure to smoking and increase in the incidence of coronary heart disease. And in the y-axis you have the change in coronary heart disease because it increases. Another criteria of causation that is important is what we call the dose response. And you know this is measured particularly in when we try to demonstrate the causal relationship between smoking and lung cancer. You know that the more the number of year packs of smoking increase, the more the risk of lung cancer increase. This is exactly this graph. So packs of cigarettes smoked per day. If it is 0, the incidence is very low. This is the incidence among non-smokers. You see how it increases linearly when the person smokes half a pack, 1 pack, 1.5 pack, and 2 and plus. So you see the difference. Between 0.5 and 2 and plus, it increases 4 times, from 47 to 166, almost. شفتوا? There is a dose response. This is a dose response effect. So be careful when you read the curves. If the x-axis give you the number or the importance of exposure, this is dose response curve. Don't mix up things. You need to read carefully the curves. And finally, there are a lot of other criteria that were proposed by Austin Bradford Hills as criteria of causation. And the most important, we discussed them, the first 3 in details with examples. There are others, like consistency, plausibility, consideration of alternate explanations, experimental demonstration, specificity of the relationship, and coherence with other studies. You have to know them, but these are the most 3 important. So, and that's all from me, and your take-home messages are: causal relationship between factors and disease is not easy to establish. It requires, in addition to the strength of the association, other criteria, particularly temporality and dose response effect, and other. Significant association must be strong between causal factors and disease. If you have very strong relationship, most likely there is a causal association, but it's not enough. Exposure to factor must precede the disease, and this is an important condition for causal relationships. Prospective cohort studies are needed to establish temporality, as well as strength of the association. And we measure the relative risk, and you are sure that the exposure precedes the disease. So, cohort studies are really appropriate. Dose-response relationship is compulsory also. Other criteria are explained also in Austin Bradford Hill's criteria of causation. Okay, do you have questions? What's the relationship between study designs and causality? ايش هي العلاقة ما بين الدرس الأول والثاني؟ Why do I teach you two conferences? What's the relationship? لأنه الأسوسيشن is one of the criteria of causation والtemporality. وهذوما study designs يجمعوا this, we find them in study design. The association is in the cohort studies, the ratio of incidence to relative risk, and temporality is in cohort study also. Strength of the association can be also measured through case control studies. Do you have other questions? فاهمين كل شيء? I'm sure everything will be fine for you, and inshallah استفدتوا. It's a shame that this classroom is not full of students, because they will miss understanding the study designs. This will be useful for you in your future research career, and you will start using these concepts in community-oriented research projects from next year, inshallah. Okay, thank you very much, and I hope to see you in the next conference. يلا، بأمان الله. العفو.